Hello, this is Praveen Kumar Tirlangi. Welcome to a new episode in our series on antimicrobial approaches to gram-negative infections. Today, in chapter 4, we will focus on less common and uncommon gram-negative pathogens. These organisms are not necessarily rare, but they are encountered less frequently compared to Acinetobacter, Klebsiella, E. coli, and Pseudomonas, which we have already discussed in detail. If you haven't listened to the first three episodes, I would suggest starting from episode 1 and progressing sequentially to get the full context. Today, we will be focusing on these organisms: spice, Stenotrophomonas maltophilia, Elizabethkingia, Chryseobacterium, and Burkholderia cepacia complex. So, spice organisms are the group of organisms which includes Serratia, Pseudomonas, Proteae, which are indole positive, Proteus, Providentia, and Morganella, Citrobacter, and Enterobacter. So, one of the most important issue when we are discussing about these spice organisms is to, to have an ability to produce inducible AMC enzyme. We have discussed in our previous chapters that if a gram-negative bacteria is producing AMC enzyme, it will be resistant to third generation cephalosporins but susceptible to fourth generation cephalosporins like cefepime and carbapenems. So whenever you have a gram-negative bacteria in culture which constitutively expresses AMPC, you can easily see that in the culture report. So in culture report, you can see that it is resistant to third generation cephalosporins and susceptible to cefepime. But in the spice group of organisms, the AMPC is inducible. That is, when you see the culture, it is possible that you are seeing a susceptibility report to third generation cephalosporins like ceftriaxone and ceftazidime, and you think that it is susceptible and you start the patient on ceftriaxone, and then the bacteria start producing AMPC, so which will eventually lead to rebound bacteremia, treatment failure, and increased mortality. So this AMPC production, inducible AMPC production, is clinically very relevant in Klebsiella aerogenus, which usually previously called as Enterobacter aerogenus, and Enterobacter cloacae, and Citrobacter fruendi species. Even though Serratia also produces AMPC, the exact clinical magnitude of this production is not known. So there is a trial called Marino 2 trial. Marino 1 trial is a trial which compared piperacillin tazobactam with meropenem in enterobacterials. But Marino 2 trial had seen the impact of inducible AMC production in these organisms, in which Citrobacter and fruendi, Enterobacter aerogenus, and Enterobacter cloacae, they had a very significant clinical impact. Approximately one quarter of the patients they fail if they are started on third generation cephalosporins. However, the trial sample size is very small, so probably we cannot definitely conclude this that AMC production is clinically not that important in spice, but that is there for the debate. So this is how it works. So if you are trying to kill the bacteria by giving an antibiotic which will attack the peptidoglycan layer, the fragments of peptidoglycan layer will go into the cytosol. Normally, this AMC beta lactamase production is inhibited by AMPR, and whatever peptidoglycan fragments are there, they are degraded by AMPD. But if there are a lot of peptidoglycan fragments into the cytosol where AMPD is overwhelmed, these peptidoglycan fragments will inhibit AMPR, which is inhibiting in turn AMC beta lactamases, eventually leading to AMC beta lactamase production. So to make it simple, basically bacteria is seeing that you are trying to break the peptidoglycan layer and it is producing AMC, that is inducible AMC beta lactamases. So in the spice organisms, it is very important to understand the resistance patterns, because these bacteria which are which belong to Proteae, that is Proteus, Morganella, and Providentia, they are intrinsically resistant to colistin and polymyxin. So if you have a bacteria like Proteus, Morganella, Providentia, and if it is carbapenem resistant, then you cannot go and treat this bacteria with Citrobacter. Probably you have to look into the newer drug options, because these are with colistin, because it is intrinsically resistant to colistin. Whereas in Serratia, Citrobacter, and Enterobacter cloacae, you don't see intrinsic resistance to colistin. However, the amount of carbapenem resistance among these organisms is gradually increasing. The prevalence is increasing. You can see a lot of species of Enterobacter in India producing NDM, Citrobacter producing NDM. So this is not a good news. Then all these bacteria belonging to spice organisms or whatever organisms which we are going to discuss, all of them have something in common. They have a ability to form biofilm. they have a very peculiar patterns of resistance, some of them being resistant to colistin, some of them being resistant to carbapenem. So they survive in the environment in ICU where you are using a lot of antibiotics. All this can produce variety of clinical syndromes including VAP, HAP, post-surgical infections, COTY, meningitis, and CLABSI. Some of the bacteria have a very specific clinical syndromes, but all of these bacteria can cause all these infections. But in some clinical scenarios, we really have to think about a very specific clinical syndrome. So we will be discussing about a very specific clinical syndromes happening with this bacteria. Look at this Serratia. As undergraduates, we always read about Serratia causing pseudohemoptysis. But why is it pseudohemoptysis? Why it is not true hemoptysis? It is because it is not blood. It is a production of a pigment called proteosin. Now this proteosin is not produced in the body temperature. So you will not see that blood coming from alveoli. Rather, this bacteria will be forming a biofilm on the endotracheal tube, or for that matter in the airway, where it can produce proteosin and patient can have a red colored sputum looking like hemoptysis. But when you look at the microscopy of the sputum, there won't be any RBCs. That is how you realize that it is probably a serratia colonization of endotracheal tube, which may or may not require treatment. One of the most important aspect of serratia again is ability to produce serolysine, and this is a very potent metalloprotease, and this is the reason exactly why we are seeing more and more cases of infective endocarditis, especially in IV drug abusers with serratia. Serratia has the ability to cause meningitis, especially neonatal meningitis, and it can also cause necrotizing fasciitis in immunocompromised patients. So these are not the common bacteria which we think. So if you have a patient with necrotizing fasciitis in immunocompromised, probably you also have to think about a possibility of group like spice, especially Serratia. So, as I said, there are increased reports of serratia endocarditis. Even we have seen a case very frequently with prosthetic valve endocarditis caused by serratia. So, there is one good retrospective review where they have shown that most of the young patients who are IV drug abusers, they are developing serratia endocarditis. The important lesson we have learned in this particular study is that in intravenous drug abusers, serratia often causes left-sided endocarditis rather than right-sided endocarditis. Usually in IVDU, we expect that it should cause right-sided endocarditis, but I think one of the explanation could be the amount of inoculum, because most of the times it enters the bloodstream through contaminated water or equipment, probably leading to very high bacteremia. Unlike a typical skin flora that gets trapped in the lung capillary filter, serratia can easily cross the pulmonary circulation and reach the left-sided heart, and it adheres to walls of the damaged walls, which are very common in IV drug abusers, probably due to repeated bacteremia or particulate injury, and also the virulence of serratia, like because of the production of very strong metalloproteases like serolysine. So important, these patients, people who received a combination therapy had a better outcomes. People who had underwent surgery, 40% of them approximately had surgery with 20% mortality overall. So people who underwent a procedure, they had a better outcome compared to the patients who did not have procedure. But this is again a retrospective cohort, so there will be definitely a indication by bias. So basically, if you have a case of serratia endocarditis, probably you want to do a surgical intervention. It could be whole surgery, or it could be transcatheter aspiration of the vegetation, and probably we want to give a combination of antibiotic rather than giving monotherapy. Let's go to the second bacteria, Proteus. Proteus is pleomorphic, and Proteus vulgaris and Proteus mirabilis, two species are very important. Proteus mirabilis is a common species. One of the most important aspects for Proteus is it has the ability to swarm. So even that you can see in urine culture reports, a swarming growth actually tells, without gram staining or identification, you can tell that this is Proteus. So swarming motility actually helps the Proteus to ascend into the upper urinary tract. So it causes pyelonephritis. It causes a lot of urease production, which makes the urine alkaline. That will actually lead to the precipitation of triple phosphate crystals. Like that is one of the reason why they will have a staghorn calculi. So Proteus causes upper urinary tract infection with staghorn calculi obstructing the urinary tract, leading to a lot of pressure and dilation of calyces, formation of xanthogranulomas, and that is called xanthogranulomatous pyelonephritis. This is how xanthogranulomatous pyelonephritis will look on radiology, like a bear paw appearance. Many of the bacteria like E. coli, Pseudomonas, Klebsiella can also cause, but Proteus is one of the cause or to form xanthogranulomatous pyelonephritis. So young females with recurrent UTI landing up in CKD, one of the reason is xanthogranulomatous pyelonephritis. Unfortunately, it won't respond to medical treatment. Most of the times we have to take the kidney out. So xanthogranuloma is not just restricted to kidneys. Xanthogranulomatous inflammation can happen in even gallbladder, in lung. But proteases is definitely one of the reason for the xanthogranulomatous pyelonephritis, which is unfortunately associated with a very poor prognosis. How about Citrobacter? Citrobacter, we have two species, Citrobacter freundi and Citrobacter kocheri. Among them, Citrobacter kocheri is one of my favorite. It has a plasmid encoded neurovirulence factor, so it is one of the reason for brain abscesses in newborn. So among the organisms which cause neonatal meningitis, if there is a formation of brain abscesses, you have to think about Citrobacter kocheri because of this plasmid encoded neurovirulence factor, which causes extensive liquefactive necrosis. So you see a rapidly expanding multiloculated abscess with a poor capsule formation. So it used to be called as Citrobacter diversus. You can see that 80% of the cases with Citrobacter had brain abscess compared to less than 10% due to other gram-negative meningitis. Obviously, there are other bacteria like Strep viridans group which can also cause brain abscess. But if you look at the gram-negatives, Citrobacter kocheri is definitely associated with a high risk of formation of abscesses in newborn where the blood-brain barrier is not yet developed. These patients might not have blood culture positivity, only one third of them can have blood culture positivity, can lead to diagnostic delay unless you are intervening in neurosurgically. So let us again look into the signature syndromes. We have discussed about cepacia, which can cause infective endocarditis in IV drug abusers, necrotizing fasciitis in immunocompromised hosts. Proteus, we have discussed xanthogranulomatous pyelonephritis. Among Citrobacter kocheri, we have discussed brain abscesses. Look at Providentia. Providentia is it is a organism which causes a lot of biofilms in biofilms in plastic material. So most of the patients who are prolonged catheterized and they are having UTI, Providentia is definitely one of the possibility we want to keep. What about Morganella? Among the spice group, Morganella has the ability to form a lot of gas. So if you are having gas forming post-surgical wound infections, don't just think about a possibility of anaerobic infections or a background of diabetes where E. coli Klebsiella can also, or probably non-typhoidal salmonella can also cause gas formation. Morganella is one of the reason why patient can have a gas production and surgical wound infection. So this is again very important. Let's move to Stenotrophomonas maltophilia from Serratia, okay, spice organisms. Okay, so Stenotrophomonas maltophilia, one has to know that it is intrinsically resistant to carbapenem. So if your ICU is using a lot of carbapenems, probably there could be Stenotrophomonas coming up. So if the patient is on carbapenems not responding, besides carbapenem resistant organisms, you also think about possible bugs which are intrinsically resistant to carbapenems. One of the most important thing about Stenotrophomonas, again, it produces a lot of proteases and it thrives in a very nutrient poor environment and low immunity environment. So one of the classical syndrome that is caused by Stenotrophomonas maltophilia is a diffuse allular hemorrhage in febrile neutropenia patients. We'll discuss how. So before that, there is a very peculiar inducible L1 L2 beta lactamases in Serratia. So L1 beta lactamase is a MBL beta lactam, and L2 is serine beta lactamases. The issue is these are inducible. That is, when you are looking at the susceptibility report of the patient, it might show that it is ceftazidime susceptible, but the moment you give it to the patient, there could be treatment failure. Very similar to AMP production, the same AMP-D, AMP-R regulatory system is there here also. This eventually led to L1 and L2 beta lactamase production, which can lead to treatment failure. So the drugs of choice for the treatment of Stenotrophomonas are cotrimoxazole, minocycline, and quinolones. Interestingly, ticarcillin clavulanic acid also retains activity. Even though it is not available widely in our hospital setup, actually ticarcillin clavulanic acid is available. Klebsiella will be intrinsically resistant to ticarcillin clavulanic acid, but for the treatment Stenotrophomonas, which doesn't involve CNS, probably this is one of the option available for the treatment. So we were talking about a possible diffuse ulnar hemorrhage in febrile neutropenia. Now look at Stenotrophomonas. It is a carbapenem resistant organisms, and if the patient with febrile neutropenia for any reason is on carbapenem, it will get selected out. and it will not depend upon neutrophils for its nutrition. This might sound counterintuitive, but most of the bacteria, they do not have that much of enzyme production to degrade tissues. They rather depend upon the neutrophils to come and degrade tissues and provide amino acids and other essential nutrients for them. So many of the bacteria will not be able to establish a full blown infection in a neutropenic host. This is very interesting. But in Stenotrophomonas, because it can survive in a low nutrient environment, and it can produce a lot of enzymes, metalloproteases, it breaks down all the alveoli, extends into the infection to the endothelium, causes the endothelial damage, and suddenly you see patient will have diffuse ulnar hemorrhage. Interestingly, whatever couple of cases I have seen, these are the patients they might not have that fever in febrile neutropenia. Most of the times when we see cases of febrile neutropenia, we expect fever, but with Stenotrophomonas, diffuse ulnar hemorrhage, the DAH could be the first presentation. We might label it to the bland hemorrhages related to thrombocytopenia, but definitely Stenotrophomonas is something which we should definitely think about. It can also cause all the ICU and device related infections. Stenotrophomonas can coexist with Pseudomonas or Burkholderia species as a colonizer in patients with chronic bronchiectasis, and coexistence of Pseudomonas and Stenotrophomonas, it's not a good news, right? So Pseudomonas you are trying to treat with carbapenems, and then there will be increased proliferation of Stenotrophomonas species. As we discussed, the treatment is cotrimoxazole with or without combination with minocycline and levofloxacin. So quinolones are kind of head-to-head compared with cotrimoxazole, and they are found to be as good as cotrimoxazole. And when they compared the combination therapy with monotherapy, it was found that combination therapy is probably associated with higher side effects compared to monotherapy. So unless the patient is sick, very sick, or severely neutropenic, probably monotherapy should be good enough. Ceftazidime avibactam is actually effective against L2 beta lactamase, that is class A carbapenemase produced by Stenotrophomonas maltophilia. So probably ceftazidime avibactam is one option. If the bug is producing both L1 and L2 beta lactamase, a combination of ceftazidime avibactam with aztreonam or aztreonam avibactam can also be a good combination for Stenotrophomonas. So Stenotrophomonas, the other drugs like cefiderocol, they have good in vitro activity, and also cefepime-zidibactam has a very good in vitro activity. So where there are multiple good bacterial antibiotic options even for Stenotrophomonas now. Yeah. Let's move to the next bug, Elizabethkingia. This is one of the most interesting bacteria because this has two metallo-beta lactamases which are chromosomally produced. So basically, it doesn't take plasmids. It doesn't have a good plasmid uptake. So it basically depends upon its ability to produce metallo-beta lactamases. So many of the bacteria, if they produce two different metallo-beta lactamases, then there is a lot of metabolic compensation that is required, can lead to a fitness cost for the bacteria. But Elizabethkingia, it produces two class B metallobeta lactamases, BLA-B and GO-B, and it also produces a class D serine beta lactamase, CMA, very same class as OXA48, and BLA-B and GO-B are same class as NDM, BIM, or IMP. So that is the reason why it is intrinsically resistant to all the beta lactam antibiotics, and also aminoglycosides, because along with the efflux pumps and porine changes. So basically it is resistant to many of the drugs. Again, the treatment options you are left with are cotrimoxazole, minocycline, and fluoroquinolones. The problem with Elizabethkingia meningoseptica is the common syndrome is neonatal meningitis, especially neonates who requires the neurosurgical interventions for some reason. There could be higher incidence of VP shunt infection in these patients. So at that point of time, in pediatric age group, again, cotrimoxazole can be associated with kernicterus, and if you are trying to give cotrimoxazole, if there is side effect, you don't have much options which are safer. Like minocycline, you have some issues, the teeth discoloration or deposition of the minocycline on the bones. Similarly with quinolones. People do give vancomycin and rifampicin with variable success, but vancomycin or rifampicin is not really a great option to treat Elizabethkingia meningoseptica meningitis. So even though if you're dealing with a kid who has a neurosurgical meningitis with Elizabethkingia meningoseptica, I think there are a lot of other issues rather than being worried about tooth discoloration or deposition of antibiotic in the bone. I think these patients should be treated with a combination of antibiotics, because Septran, minocycline, quinolones, they all have good CNS penetration, where vancomycin and rifampicin are not great if you compare with the other antibiotics. And vancomycin, it typically used for gram-positive infections, and it has some in vitro susceptibility to Elizabethkingia. However, you cannot depend upon in vitro susceptibility, and there is no big data to suggest a combination of vancomycin rifampicin over ceftriaxone, minocycline, and fluoroquinolones for sure. So in Elizabethkingia also you have three different species: Elizabethkingia meningoseptica, and Elizabethkingia anopheles, and Elizabethkingia miricola. So there is one old study where you can see that the prognosis of Elizabethkingia meningoseptica is much better compared to Elizabethkingia anopheles and Elizabethkingia miricola. So you can especially see in the pediatric group there, neonates have really done well with meningoseptica infection, probably because you know the syndrome. Probably you treat the bug early if you recognize it. But in adults, then the prognosis is a little bit poor, not just because of the virulence of the bacteria, but probably the patients are already very sick to start with to develop Elizabethkingia infection. Let's move to another bug, Chryseobacterium. Chryseobacterium is not very interesting like Stenotrophomonas and Elizabethkingia to produce different enzymes which are very specific for Chryseobacterium. It does has one metallobetalactamase called IND metallobetalactamase, and it doesn't have very specific clinical syndrome. It usually stays on the biofilms. So if the patient is on some bioprosthetic material, ET tubes or VP shunts, it goes and infects in patients who are having this long-term bioprosthetic catheters like peritoneal dialysis catheters and stuff. So it is again intrinsically resistant to colistin. That is one of the reason why it is important. So it can have a carbapenem resistance because of IND beta lactamase. So all these bacteria, they respond well to the probably a combination of cotrimoxazole, quinolones along with minocycline. So you can see that Stenotrophomonas, we have L1, L2 beta lactamases. Elizabethkingia is the only bacteria with two chromosomally encoded metallobeta lactamases, and Chryseobacterium produce the IND metallobeta lactamase. Chryseobacterium is intrinsically resistant to colistin because of altered lipidae. So is Elizabethkingia, but Stenotrophomonas colistin can have some activity, right? Let's go to the next bug, Burkholderia cepacia complex, which again has Burkholderia cynoshepicia, Burkholderia multioverans, and Burkholderia vietnamensis. Being in Manipal, we keep seeing Burkholderia pseudomallei, which is nothing but melioidosis. So recently we had a case who is otherwise immunocompetent, and he was in shock and he crashed within 24 to 48 hours, succumbed to the illness, and the blood culture was growing Burkholderia cepacia. So we called the microbiology to ask whether it is really Burkholderia cepacia or Burkholderia pseudomallei. They actually said we also thought the same. Probably it is melioidosis because the season fits. However, they have confirmed that it is Burkholderia cepacia. So can Burkholderia cepacia cause uh, septic syndrome in otherwise immunocompetent patients? This is a very important question. Let's try to answer that. Burkholderia cepacia, again, we know Burkholderia cepacia in patients with bronchiectasis and cystic fibrosis. So the natural history of bronchiectasis is initially the patients will get colonized by staphylococcus and H influenza. Over the period of years, you see these patients are slowly colonized with pseudomonas, probably because you are treating the patients with antibiotics which are not effective against pseudomonas. Patients are on macrolide prophylaxis, and pseudomonas is resistant to macrolides. So eventually you see these patients getting colonized with pseudomonas aeruginosa, and then over a period of time you'll be treating these patients with probably inhalational tobramycin or other inhalational options which are there for the treatment of pseudomonas colonization. Then you slowly realize that this patient starts having another bug called Burkholderia cepacia. So someone with cystic fibrosis or bronchiectasis came to your OPD, and if you are isolating Burkholderia cepacia, then it actually tells that the patient had a very long history of recurrent exacerbations and treatment in these patients. Again, in chronic granulomatous diseases, we see Burkholderia cepacia infections, sometimes something called cepacia syndrome. We'll be discussing more on it. So Burkholderia cepacia again is a very strong catalase producing organism. So in chronic granulomatous disease, we know that catalase producing organisms can establish infection because of the underlying immunodeficiency, especially nocardia, aspergillus, Burkholderia, serratia. So in CGD patients, you see, actually the most interesting part is we started seeing a lot of Burkholderia infection patients with influenza, And influenza virus actually can cause reduction in NADPH oxidase functionally, which is very similar to CZD. So probably for influenza, you can say that it is transient CZD. It is no brainer that post-influenza Staphylococcus aureus is very common. Post-influenza Aspergillus is very common. Then why not post-influenza Burkholderia cepacia? Probably when you are isolating Burkholderia cepacia, you should also think about a possible co-infection with Aspergillus or Staphylococcus in these patients. So we see Burkholderia cepacia complex again in ICU patients and transplant patients, especially lung transplant patients, is very very important, and post chemotherapy. So one other thing about Burkholderia cepacia complex is among the Burkholderia Cenocepacia, multiorens, and Vietnamensis, there is a clone called ET12 clone in Burkholderia Cenocepacia. So this is something which can behave very virulent, and it causes something called cepacia syndrome, where the patient comes with bacteremia, septic shock. So some of the patients with cystic fibrosis, they can get colonized with this E212 clone, and in cystic fibrosis clinics, this clone can spread from one person to another person. This is the biggest worry in patients with cystic fibrosis. So we'll discuss more about this ET12 clone. So, so among we have discussed that among this species, Burkholderia cenocepacia is more virulent. So this ET12 clone has this Burkholderia cepacia epidemic strain marker pathogenic island, which is one of the reason for the production of cable pili. And there are some enzymes, JMP metalloproteases, which degrade the tissue, and also the lipopolysaccharide triggers a strong interleukin 1 beta and TNF alpha. We will be discussing a lot about immune response to different bacteria in coming sessions. Let us complete with antibiotics for now. But remember that the endotoxin of Burkholderia cepacia, Cenocepacia, especially ET12 strain with BCSM pathogenic island, can actually trigger a very sepsis-like syndrome suddenly in a patient who is otherwise colonized with Burkholderia cepacia for long time. So these are cable pillars. See, these pillars are so long, and they attach to the epithelium very strongly. So if you're looking at a patient who has both Pseudomonas and Burkholderia Cenocepacia or Burkholderia cepacia complex, the logic is, see, two bacteria has to compete for the available nutrients and irons. Probably one will try to inhibit other, but Pseudomonas tries to be on the superficial layer of mucosa, whereas Burkholderia cepacia will be on deeper layers. So basically they have a very specific niche where they stay, so they can be complementary to each other. In fact, presence of both Pseudomonas and Burkholderia cepacia indicates that there is going to be a rapid progression of rapid worsening of the lung parameters in the near future. So Burkholderia cepacia, again, just like Burkholderia pseudomonas, it is both extracellular and intracellular. Pseudomonas is basically extracellular, it stays on the superficial layer, but Burkholderia cepacia is also intracellular. So it is impossible to eradicate Burkholderia cepacia. So you can give inhalational tobramycin for Pseudomonas, but it won't work for Burkholderia cepacia. In fact, Burkholderia cepacia is intrinsically resistant to aminoglycosides and colistin. That is one of the reason why patients who are colonized with Pseudomonas getting inhalational tobramycin are more likely to be eventually colonized with Burkholderia cepacia complex. Why I am telling you this is, it's impossible to eradicate because it stays in the intracellular area, and the moment you are planning for a lung transplant, this becomes an absolute contraindication. So patient who is colonized with Burkholderia cenocepacia or Burkholderia cepacia complex, if you do transplant, you are expecting it to come back, and most of the times it will be cepacia syndrome, which is very difficult to manage. Among the three species, again, there is some literature to say that probably you can do transplant in patients colonized with Burkholderia multiorens and Vietnamensis, and not with Burkholderia cenocepacia, especially not with ET12 clone. So Burkholderia has very interesting mechanisms of resistance. Even Burkholderia pseudomonas has two important mechanisms of resistance are RND efflux pumps, RND3 and 4, which causes resistance to carbapenems like meropenem. Then they also have PEN-A class A beta lactamases, which cause resistance to many of the cephalosporins. Ceftazidime is relatively resistant to efflux pumps mediated mechanism, probably better than other beta lactam antibiotics in the context of PEN-A beta lactamases. However, if there is a lot of production of NA-beta-lactamase, there could be failure of treatment with ceftazidime. So the drugs of choice which are going to act in these patients are ceftazidime, carbapenem, and cotrimoxazole, very similar to Burkholderia pseudomallei, right? So mechanisms of resistance, most important mechanisms of resistance, beta lactamases and RND efflux pumps, including RND3 and 4. Sometimes it can have an extended spectrum AMC, which can again hydrolyze the ceftazidime. So excessive production of beta lactamase or extended spectrum of AMC, which can metabolize ceftazidime, could be the resistance mechanisms for ceftazidime, and efflux pumps are the common resistance mechanism for carbapenem. So the thing about ceftazidime in Burkholderia pseudomallei, for that matter, Burkholderia cepacia complex, it has a very high activity, strong binding to penicillin binding protein 3 for, of these species. That is the reason why many of the other cephalosporins like ceftriaxone or cefepime won't be that effective, whereas ceftazidime is one of the drug of choice for these patients. There could be higher resistance in Burkholderia cenocepacia. So when we are saying Burkholderia cenocepacia, it is higher virulent and it has a higher resistance, probably because of the penne beta lactamase production. So we have discussed about different syndromes like so cystic fibrosis patients chronically colonized with Burkholderia cepacia. ICU infections can happen in patients who are on polymyxin or aminoglycosides. But suddenly, you can see patients with cystic fibrosis who is having Burkholderia cepacia colonization. You are treating them with long-term antibiotics, doing otherwise okay. Then you suddenly see they will land up in emergency very poorly in a septic shock-like condition. This could be because of the acquiring ET12 lineage. Some of the triggers, like some viral infections, for that matter, steroids, can actually trigger the cepacia syndrome. So uh, this can happen with viral infection, steroid exposure, or acquirement of new clone like ET12 clone. So this is kind of very common. We keep discussing about vaccination in patients with chronic lung diseases, but one of the practice which people are not leaving is prescription of inhalational corticosteroids in patients with COPD or bronchiectasis. These patients, the chronic inhalational corticosteroids are not useful except in very minor subsets. In COPD patients, probably with the eosinophilia predominant COPD patients, it might be helpful, or COPD patients with very frequent exacerbations, it might be helpful. But in other patients, you are basically destroying the local microbiome by giving steroids, and that definitely has shown beyond doubt to increase the number of exacerbations and associated with high mortality. So probably we should be avoiding these practices. Probably giving just vaccination for influenza and pneumococcus is not going to help a patient who is colonized with Burkholderia cepacia, right? So viral infection, steroid exposure can always happen. These patients might get admitted with the influenza or some other viral infection, and you think it is ARDS. You want to give a small dose of steroid for these patients, and then there you'll end up in cepacia syndrome with bacteremia and very high mortality rate. Same is the story in patients with lung transplant. We have discussed that in patients with Burkholderia cepacia, Cenocepacia or cepacia complex, it's very difficult to eradicate. So if you are transplanting a patient who is already colonized with Burkholderia cepacia complex, there is a risk of post-transplant cepacia syndrome, and that is associated with high mortality. And it is mainly in Cenocepacia, the mortality is quite high, up to 70%. But whereas in non-Cenocepacia, probably you can go ahead with transplantation. So diagnosis we have to do with MALDI-TOF, which culture and MALDI-TOF which we have available, and for ET12 detection you can do a whole genome sequencing or a sequencing of RECE. In cystic fibrosis patients, you have to keep monitoring whether there is a Burkholderia cepacia colonization in these patients, because the treatment will differ. The therapeutic options has been discussed are meropin, carbapenems, and ceftazidime, Septran, and in severe disease,